The assessment of SpVO2 is a good guide to assessing the oxygen delivery versus uptake. Besides the hemoglobin, there are 5 other factors that need to be altered to improve the supply. Selection of oxygenators with a higher surface area and rated flow, increasing the ECMO flow, increasing the sweep FiO2, and sometimes even ventilator FiO2, and decreasing the recirculation factors all help to meet ECMO goals without transfusion. On ECMO, decreasing the temperature may be the easiest method of decreasing oxygen demand. There is an obvious correlation to the HB and the oxygen carrying capacity of the blood, and can help improve the oxygen supply when all other methods to improve oxygenation on ECMO. The starting numbers matter prior to ECMO initiation, and hence aggressive correction of hemoglobin and coagulopathy helps not only to meet ECMO goals immediately, but also to decide on heparinization dose and targets if there is no factor deficiency. Anticoagulation response differs in some patients who drop platelets rapidly due to either sepsis or heparin-induced thrombocytopenia. Antithrombin deficiency too makes heparinization challenging. Some centers empirically treat suspected or confirmed low antithrombin levels with fresh frozen plasma. However, giving standard FFP alone may not be enough, as the volume needed is more. So because antithrombin is available as 1 unit per ml of FFP. The configuration and presence of multiple extracorporeals complicate the heparinization targets as discussed. Certain patient factors like underlying liver or kidney disease, pre-existing clotting or bleeding tendencies further make the transfusion triggers different in different patients. Point of care coagulation tests are very important to achieve a good balance of heparinization and help one to stick to restrictive transfusion triggers. Assessing coagulation in critically ill patients is complex, and addition of ECMO and anticoagulation increases this degree of complexity significantly. Ideally, one would prefer to measure the global function of coagulation to best tailor anticoagulation therapy, and a number of whole blood and plasma-based tests to assess coagulation is available. However, each have limitations when used to monitor anticoagulation and Ecls applications. A significant Thus, an anti-10A value performed in one machine may vary from that in another machine. Using one method of monitoring is likely no longer acceptable. However, using multiple methods multiple times a day also is not acceptable. ACT has been used for decades to monitor heparinization, but it can be affected by factors like anemia, hypofibrinogenemia, thrombocytopenia, and other coagulation factors deficiency, which hopefully gives an accurate reflection of the patient's overall anticoagulation state. It is low cost and available 24 hours in most centers. Anti-10A assays, considered the gold standard, are not available easily in India, and though they are not affected by coagulopathy, thrombocytopenia, or dilution, they are affected by hyperlipidemia, hyperbilirubinemia, and high plasma-free hemoglobin, which is very often present in critically ill Ecls patients. In India, most labs run APTT, and most centers use APTT to titrate heparin primarily or in adjunct with ACT in adult patients. Infants have baseline prolonged APTT values, and as a result, it has been thought that APTT would be less reliable. However, point of care devices are available now, and a recent study in pediatric Ecls showed that APTT correlated well with the dose of heparin, better than ACT, and the dose correlation improved with increasing age. TEG and ROTEM provide information relating to multiple phases of coagulation and whole blood, which is extremely relevant to Ecls patients since they are more than one reason for coagulation abnormalities. Heparin responsiveness can be evaluated by examining the difference in R or CT times between tests with and without heparinase, which may be beneficial when there is concern for heparin resistance. It is the best test to decide on various products and procoagulant factors in bleeding patients to achieve directed correction and avoid overcorrection of products, which itself is very harmful. platelet function, hyperfibrinolysis, early DIC can all well be identified. Also, recommendations for transfusion cutoff for PRBC to maintain hemoglobin levels of 12 to 14. Platelet count targets are 75,000. The threshold for platelet transfusion may be reduced in older patients with an inherent lower risk of intracranial hemorrhage and who are stable on ECMO. In addition, there may also be significant platelet dysfunction despite regular platelet transfusions. Platelet function tests can be performed to measure the platelet activity and aggregation. For patients with massive life-threatening bleeding, it is appropriate to use a massive transfusion protocol. For centers with whole blood availability, it can be considered for patients with massive bleeding within a massive transfusion protocol. Cryoprecipitate transfusion at fibrinogen levels below 100 to 150 milligram per dl. Antifibrinolytic therapies such as alpha-amino, eproic acid, and tranexamic acid are used only in ECMO patients undergoing surgical procedures. Peg and rotem can also be performed to determine if antifibrinolytic therapy is contraindicated if the patient has an underlying hypercoagulable state, such as DIC, in spite of active bleeding. Recombinant activated factor 7 7A and prothrombin complex concentrates can be considered for refractory bleeding during Ecls despite platelet transfusion and correction of all other coagulation factor deficiencies. It enhances thrombin generation and is given in doses of 40 to 90 UG per kg. However, significant reduction in test tube drainage and reduced need for PRBC transfusions may also lead, in some case reports, to fatal thrombosis after administration. So it should be used with extreme caution. Some centers will administer lower doses if more than one dose is required and not repeated too often. The rationale for transfusing a patient with low hemoglobin would be to increase the oxygen supply to the cells. Schmidt and al. Showed an increased supply in patients on ECMO who were transfused with RBC. However, animal studies have shown that the uptake remains independent of the supply over a broad range of values because oxygen abstraction, VO2 by DO2, can adapt to a decrease in supply as a homeostatic mechanism. Therefore, when cardiac output is reduced by acute bleeding or hypoxemia, the uptake can remain stable until the supply falls below a critical point. Hence, it might be reasonable to develop a parameter reflecting the supply uptake by supply for use as an ideal transfusion threshold. Hence, transfusions may be considered with focus on patients' volume status and cardiopulmonary parameters. Higher transfusion thresholds may be justified in patients with high pressure requirements. Duration of anemia again is an important factor for determination of transfusion threshold. Prevention of bleeding is definitely the way to limit transfusion requirements. No invasive lines on ECMO, optimal anticoagulation, choosing the least harmful configuration, using large cannulas to prevent hemolysis, insertion of cannulas under ultrasound guidance to prevent injury to vessels, better ECMO systems with lower priming volumes, bioline circuits, and cannulas. When appropriate, run ECMOs heparin-free. Use multiple point-of-care tests to accurately estimate heparinization. The duration of ECMO was associated with volume of transfusion and a tendency towards decreased platelet count. Hence, it is recommended to attempt to shorten the duration of ECMO. Furthermore, minimizing daily sampling could be regarded as a strategy for fewer blood transfusions. Schmidt et al. Reported that among 484 infants or children, out of which 40% were cardiac and 42% non-cardiac, while 18% were Ecpr, the transfusion volume was the largest among patients undergoing cardiac ECMO, followed by those with Ecpr. And non-survivors received more transfusions than survivors. Also, in a study by Omar et al., the transfusion volume was higher in non-survivors compared to survivors. Two retrospective observational studies were published on restrictive transfusion strategies, and in a German study of 18 patients with severe ARDS, hemoglobin concentrations were maintained between 7 and 9, and the transfusion trigger was a hemoglobin level of less than 7. Their results show that the mean hemoglobin level and hematocrit were 8.3 and 25% respectively during ECMO, which were lower than the levels found in influenza ARDS patients by Italian ECMO network. They found that the overall mortality was 38.9, but transfusion volume tended to be higher in non-survivors than in survivors. In another study, Agerstrand et al. Used a blood conservation strategy for 38 ARDS patients, which was comprised of a low transfusion trigger, a low, that is the hemoglobin less than 7, a low APTT 40 to 60 seconds, and use of auto transfusion. Their survival rate was 73% and transfusion rate was 63. They increased the ECMO flow rate instead of transfusing CRBC to maintain SpO2 more than 92%. On an average, a total of 1 packed cell was transfused, which was much lower than previously reported rates. They also noted that rates of thrombosis and bleeding complications were not remarkable. The number of transfusions rather than baseline hemoglobin was associated with higher mortality. Tosdorf et al. Performed autotransfusion in 7 patients on ECMO, and it reduced RBC transfusion volume from 6.8 to 1.9 units. The advantages of autologous transfusion are lower humoral immune response and lower infection risk, shorter length of hospitalization. In particular, the authors found that the depletion of leukocytes and platelets using cell saver in contrast to whole blood out of heart-lung machines in cardiac surgery can reduce inflammatory response and improve lung function after transfusion. In conclusion, most knowledge on transfusion strategies is extrapolated from studies in critically ill patients. Evidence for ECMO patients undergoing ECMO is limited. Recent improvements in ECMO technology decrease the need for blood transfusion, and current data support a restrictive transfusion strategy for ECMO patients. A low transfusion trigger, hemoglobin less than 7 gram per DL, is acceptable. Low anticoagulation targets are acceptable. Minimizing phlebotomy, autotransfusion during decannulation, and reducing the duration may all be beneficial. Not focusing exclusive on the hemoglobin level as a transfusion trigger. Finally, well-designed randomized controlled studies are needed to prove the benefits of strategies mentioned above in ECMO patients. Thank you.
Thank you, Dr. Jumana. That was a very informative presentation. We will probably take questions at the end of the scientific program. I would like Dr. Poonam Malhotra, one of the senior-most consultant intensivists and cardiac anesthetist, to speak on echocardiography on extracorporeal membrane oxygen. Over to you, Dr. Poonam.
Thank you. Thank you. Am I audible?
Yes, you are. Yes, you are. We can hear you.
I thought I wasn't audible. That's why I went on last time. Thank you, Dr. Muralidhar, ICCA, and the whole of the Bangalore Forum for giving me this opportunity to speak on a very favorite subject, because we feel putting ECMO is tedious and doing echo with ECMO is doubly tedious. So, in fact, it is not tedious. It saves time, it saves the patient, and it gives us fantastic results on how to go about managing our ECMO so that we all are on the same podium. So since yesterday, VV ECMO and VA ECMO discussed in detail, and I won't go into the details of the circuitry, the kind of cannulas, but suffice to say that the veno-arterial ECMO circuit is very different from the veno-venous. The gas membrane exchange, which went on in 1944 and was brought to forum of 1976 by Dr. Robert Bartlett, the father of ECMO, on a patient undergoing a ASD repair and had meconium aspiration, who was put on ECMO. This was a good many years back. The patient lives through, but what do we need more beyond ECMO is how to have a window for ECMO so that we could choose our patients rightly, we could monitor the support of ECMO, we could insert and correctly place the cannulas of ECMO, detect the complications, and decide when to wean the patient off and have a recovery and trial off on this patient. So maybe a transgastric short axis Mid-papillary view is what we need to tell us about hydration. We are all aware of it. It can easily be done through the transthoracic or the transesophageal route. It will also tell us about the poorly contractile myocardium and the need for inotropes, both in the LV or the RV failing. It will tell us of any collection outside the heart in the form of a tamponade or a pericardial effusion. Also tell us the patient going into an impending ACS, ischemia or cardiogenic shock with regional wall motion abnormalities suddenly appearing, and increase in the RA pressures telling us a lot about an impending pulmonary embolism. So what are the patients where we don't take an ECMO? Well, one of them is a aortic dissection, where you can use the upper esophageal aortic arch view, see a definitive flap, and distinguish between the true and the false lumen. Absolute contraindication is aneurysm or the aortic dissection. A relative contraindication is an aortic valve regurgitation for a VA ECMO. Why? Because with afterload increasing and the LV distension further increasing, the AR would increase more if the VA ECMO is put than a VV ECMO. So probably if much needed and an AR is there, a VV ECMO is a better choice. But a VV ECMO should not be put in a patient with severe pulmonary hypertension. You should prefer a VA ECMO there. And what to do when we have a VV ECMO? We should do two views. One of them is the bicable view at 60 to 100 degrees, where you see the superior vena cava, you see the interradial septum, the LA, the RA, the mid cavity of the RA for any cannulas, you see the IVC, and you could do a modified bicable view to see and interrogate nicely the tricuspid valve and see any gradient across the tricuspid or any velocity change. A mid-esophageal four-chamber view, as you see here, and a bicable view to rule out an interradial septum break with an ASD or a PFO is also very nicely to be done after you have seen the four-chamber view and then do the long axis view. So inferior vena cava subcostal view on a transthoracic echo is a good view to see the drainage cannulas and the IVC in the long axis on a transthoracic echo. The apical four-chamber view with dilated cardiomyopathies, these are the patients for whom we normally do put an ECMO or a VAD, and the cannulas may not be visualized very nicely on an apical four-chamber view, but on a subcostal view, you can see the cannulas, and you can also see the cannulas in a suprasternal view on transthoracic echo. But any right heart anomalies, an ASD, an interatrial septal aneurysm, a PFO, a prominent Chiari network, pacemaker or ICD leads should be ruled out before you put an ECMO on the right side as a central ECMO. So this is a Chiari network that you see in the video, and this Chiari network will obstruct your ECMO videos, cannulas. Interradial septal aneurysm, presence of a PFO or ASD is also a relative contraindication for a patient for a central ECMO. And as I said earlier, cardiac failure with severe pulmonary artery hypertension, do a VA ECMO and not a VV ECMO. ECMO and echo are very important to tell us about the correct placement and insertion of the cannulas. So not just the nature of the cannulas, we've done an echo as a baseline in a patient who's about to be selected for an ECMO and is now selected. We'll see the four chambers, the systolic, the diastolic function. We'll see the morphology in the RV and diastolic and the LV and diastolic areas. We'll see the McConnell signs. We'll see the RV wall thickness. We'll rule out a PFO, IVC, SVC sizes, a right atrium with a dilated coronary sinus, an LSVC, a Chiari network, any kind of vascular abnormalities in the limbs with a carotid Doppler up and any ultrasound Doppler in the femoral or the popliteal lesion to rule out a DVT and a RA strain or a RB strain pattern for a pulmonary embolism. All these are very important. Once you rule them out, then you can decide as a team, you're putting in a central or a peripheral ECMO. And when you're putting a central or a peripheral ECMO, the peripheral ECMO, you may not be able to see the guide wires or the cannulas, but what you can see beautifully is the status of the heart. So you can see on the bicable view, the SVC cannulas, the IVC cannulas, how they rest and correlated the axis and the return cannula on the X-ray. You can use the upper esophageal view to tell us very beautifully about the tip catheter placement in the aortic arch view. Any interatrial septum, coronary sinus enlarged, any direction or malposition of the cannulas across the tricuspid into the RV or across a PFO from the RA into the LA or the LV is migration of the cannulas, and they should be detected. Avalon cannula with the opening pointing of the outward chamber into and towards the tricuspid valve should be said very nicely. It can be seen on an echo. The venous cannula should always be positioned in the right atrium to allow optimal blood flow into the circuit, and the peripheral arterial cannula, which cannot be visualized, but imaging of the guide wire in the ascending aorta can prevent the malpositioning of the cannulas. So when the surgeon is busy putting in the cannulas on the peripheral side, it is the echocardiographer or the intensivist who should do multiple windows, the bicable view, the 4-chamber view, the 2-chamber view, the long axis view, all in the mid-esophageal area, and the transgastric mid-papillary short axis view, the transgastric gastric outflow view for the tricuspid as well as the pulmonary valve, and also the upper esophageal aortic arch view. These cannulas, single or multi-stage, can be seen as speckled images. In the echo, you can see them as speckled images, and these tell you a lot about their placement, the tip, and how they resides in any chamber of the heart. The return cannula should always in a veno-venous ECMO should be in the mid-right atrium, and the access cannula should be in the proximal IVC. Too close a cannula would cause a lot of recirculation, and one, as an intensivist, as an echocardiographer, you can tell the treating physician that these cannulas need to be pulled out if they're too close to each other. Echo is essential to check the position of the cannulas in relation to any interatrial septum, PFO, LA, tricuspid valve, coronary sinus, etc. Incorrect positioning of the cannulas and migration of the cannulas would lead to recirculation, inadequate blood flow, and myocardial injury. You must remember the mid-esophageal bicable view shows the cannulas in the right atrium, and the transthoracic subcostal view tells us everything about the tip of the cannulas, where they are located in the RA. The configurations of the cannula should be well discussed so that they can be seen in various views of the echo, the bicable view or the lower esophageal hepatic vein view. That is the 7th view, which is most essential. So the cannula position, the pericardial effusion, the IVC size, collapsibility, the follow-up of any pre-existing pathology. Patient may have had an inferolateral MI with regional wall motion abnormalities and dyskinesia or akinesia of that part of the LV. So you should see how it is worsening. Is it going? What is the wall motion score like? So, sorry, excuse me. These are some things that must be told on an echo, and these are some things that we must do an echo for to monitor the ECMO support on echo. When we are doing an echo, it is important to see the aortic valve opening. Echo tells us how the aortic valve is opening in the mid-esophageal long axis view. Any stagnation of blood in the LVOT or in the aorta or in the LA or the LV is detrimental to ECMO flows. Any pulmonary congestion, edema, hemorrhage, blood stagnation in the LV, myocardial injury will all affect the ECMO flows. Therefore, echo monitoring for myocardial contractility, the left ventricular end diastolic area, and the worsening of the mitral valve regurgitation, and most importantly, the opening of the aortic valve. It can be very nicely seen as you see it here in a M-mode echo. So opening of the aortic valve is very, very important. And if it is opening well on a transgastric, deep transgastric view or on a mid-esophageal long axis view, you're very satisfied that my patient's doing well. A mid-papillary short axis view, if you have put an IBP and there is a ECMO happening with LV distension and you want to unload with an IBP and that's not enough, or you've done an atrial septostomy or an LV venting or a LA venting or an anterograde or a retrograde LV unloading, then all these are very, very important to be first seen on an echo with these different 7-8 views. A very important thing on adequate LV unloading is monitoring the patient. And if you monitor the patient with the presence of any dyskinesia, akinesia, LV distension, aortic valve opening, worsening of the regurgitation, you know your patient's in the right hands. This was a myocarditis patient on VA ECMO, day 30s, who was very nicely bridged to recovery just by seeing the subcostal and the 4-chamber mid-apical views. We didn't get very good windows because the patient was moving a lot, but at the same time, we came to know that the regional wall motion abnormalities are there. They look transient. The trop-C was high, but not so high. And when we put the patient on ECMO, on day 7, we were decannulating the patient from ECMO. Left lower esophageal, right lower esophageal hepatic vein view. The sinuses, the congestion of the sinuses in the hepatic vein in a liver congestion patient with acute decompensation and hypertrophic cardiomyopathy. This showed an IVC dilatation with collapsibility. It showed unloading. So we gave volume to this patient. We did the transgastric mid-papillary short axis view soon after. We saw the patient was dehydrated, gave immense volume, and all the SD ratios as well as the gradients came on pulse wave and continuous wave Doppler within normal limits of being around 1. So increase in the continuous or mixed venous oxygen saturation, a decrease in the PVR, a decrease in the RV after load, an increase in the oxygen content is what an ECMO does. It also tells us, the echo also on ECMO tells us about detecting the complications, not just the circuit complications of the cannulas, circuit, bladder, oxygenator, but also those of what happens to the cannulas. They'll be oozing from the cannulas. Dr. Jumana just talked about need for blood transfusion. The oozing around the cannula is the first sign that with heparin, your patient's having hyperfibrinolysis. This patient, if left untreated, is going to have a migratory cannula, who is going to have casts around the cannulas, which will form into an LV or a LA thrombus. So something like this should be seen. Something like this, a thrombus here, is very detrimental. This is an aortic root thrombus, is very detrimental to the ECMO flows. DVR done in the right panel, and in the left panel, a bad with a thrombus around it will bring about detrimental results. IVC or SVC obstructions, lower esophageal vein collapsibility, IVC collapsibility and dilatation, color flow Doppler through the flow of the ECMO cannulas, and to rule out drainage insufficiency and drainage obstruction are all needed. A swinging heart, pericardial effusion, cardiac tamponade is the first sign to tell you that this clot around the heart is going to worsen the ECMO flows. So however much you increase the flows from 1 liter to 2 to up to 4 liters, the patient's oxygenation and the patient's pressures are not going to come up. So you need to unload this heart and do the pericardiocentesis as soon as possible. Bleeding tamponade, a cardiac tamponade should have an urgent pericardiocentesis done. This was the thrombus around the DVR that we did. These are casts which migrate from the LV and RV, and this is a venous cast around the cannula that is there lying in the ascending aorta. So when you see things like a thrombus which migrates, it's like a pulmonary embolism migrating, and you see worsening of the aortic regurgitation or mitral or tricuspid regurgitation with stagnation of blood and inability of the aortic root to happen, then you know that balloon atrial septostomy is essential to unload and unvent this, and echo comes in very, very handy here. I'd like to end here because I'm moving out of my time. But when we see LV dysfunction on a VA ECMO, the RV also becomes dysfunctional. And RV function and time to weaning, if you see an RV thrombus and you see the D-shaped RV and you see a dilated RV and LV, then you know this patient cannot be weaned off. So timing to wean with dilated IVC, SVC obstruction needs a contrast echo, and the contrast echo will show a very definitive thrombus in the RV. And this thrombus in the RV, using the integrated ECMO that we did and ruling out the complications, has to be surgically maneuvered and surgically removed with good clinical judgment, hemodynamic parameters, and good echo variables telling us what are these variables, that an ejection fraction more than 35 to 40%, an end diastolic diameter of less than 55 millimeters, a velocity time integral of more than 10 centimeters, aortic valve opening very nicely without any aortic regurgitation worsening, and absence of any LV distension or dilatation. My patient is ready to be weaned off from ECMO. So echo parameters tell you so much about the patient selection, tell you so much about the cannula placement, tell you so much about the complications, the monitoring. You can go ahead and do a CT angio on a patient and see the competition between the native circulation coming back and the ECMO circulation. And I would like to end and say that echo is fundamental at the time of insertion of the cannulas, for daily surveillance and monitoring of the heart during its recovery, on how to wean the patient from the cannulas. The tissue Doppler imaging with systolic aortic velocities are coming up in a very, very big way to tell us as a load independent marker about the presence or absence of ECMO doing well or not, and how to wean off ECMO. I would still like to rest on three parameters: absence of an LV distension, opening of the aortic valve, and my aortic valve VTI or LVOT VTI more than 10 centimeters with a end diastolic area across the LV as less than 55 millimeters. Strong echocardiographic artifacts may be generated from wires and cannulas, and image intensifiers in the cath labs may overcome this drawback. And a lot of chest x-rays can be correlated with echoes. A lot of studies are there. Echo protocols need to be maintained for every echo patient. Weaning from VV ECMO relies on assessment of oxygenation and pulmonary compliance, but I wish every VV ECMO is weaned off by seeing the condition of the RV, the LV, and absence of any clot or any cast, because very often we've seen that the ECMO is successful till 48 hours. The patient goes up to the ward and dies. Why? Because there was a thrombus which we left undetected by not doing an echo, and this patient did not do well in the post-op when he was walking around. The thrombus migrated maybe as an intracranial hemorrhage or a stroke, and the patient could not be revived. So those are things that are very important for us intensivists. A patient's life is needed. If you can buy an ECMO machine, which is expensive, why not do an echo, even though it is tedious? Investigations and guidelines are needed, and that is what would happen. I thank my seniors, Robert Bartlett, for bringing about ECMO, and I think all of us intensivists salute him. We had him over at Delhi SWAC ELSO 2018, and thank you so much, Dr. Mulidhar, again for giving me this opportunity.
Thank you, Dr. Pushpam, for a wonderful presentation.
I'll just escape. I'll just close.
Request Dr. Niranjan to start his presentation on transport of patients on ECMO. Yeah, thank you very much, Niranjan, for being here. You can take over, Dr. Niranjan.
I can unmute, I can talk now. How to control my slides? I can share, or you are going to?
You will have to prompt Rajiv to change the slide.
Rajiv? Hello, Rajiv, you are helping me to move the slide, or
yes, sir.
I can do it myself?
No, sir, I'll just do the needful, sir. I'm just trying to change the slide.
Okay.
Full screen is not available. Full screen is not available now, sir, for this thing.
Then what to do?
Please carry on. Please carry on.
Please carry on, sir.
Carry on?
Yes, sir.
Okay, thank you for giving the opportunity to talk on this forum. My name is Niranjan S. Chandrasekhar. I'm working as a perfusionist. I did my perfusion and I did my ECMO diploma in Paris, L'Hôpital International. And I'm working as a flying perfusionist at ICA Health Solution in Bangalore. I'm presenting today the ECMO transport. Can you change the slides? I'm going to talk about history, types of transfer, mode of transfer, and checklist, and transfer plan, and execution, and conclusion, and conclude the thing. History, there is a first ECMO transfer done, and there is 1977 and 1991. There are both papers are presented and forum. The Bartlett and the colleague is the first one. Second one is US Air Force Medical Center, published in 1991. And afterwards, both cases are pediatric one. And second one, like a third cases started in adult respiratory support and the pandemic H1N1 influenza. Afterwards, many last 2 decades, lot of ECMO patients are transferred all over the world. Next slide. These are the 2 pictures. First one they used for Beechcraft King Air aircraft. Second one is Citation 2 Jet Airline.
Hello.
Next slide.
Yes, sir.
I'm types of transfer. There are 2 types of transfer. There is internal transfer and external transfer. There are internal transfer where we can transfer the patient, already patient on ECMO. They want to do some procedure in OT or cath lab, or you want to do some investigation, some kind of CT, or you want to do for chemotherapy. And sometimes patient is a long ECMO patient, we can do it for rehabilitation, like doing the physiotherapy, taking walking outside, all those things. Like, can you play the video? First one video. Can you are you able to play the videos?
No, sir.
Oh,
I don't have the files.
these are the pictures I want to show. These are really interesting pictures. Next one. The patient is walking. This is a patient on fem cannulation. A patient is taking for rehabilitation. Lot of videos are there. I don't think so is able to play. Can you go back? Rajiv, can you able to do something for playing videos? Rajiv?
Please click preview
Niranjan,
after.
we want to start.
Rajiv, can you do something?
No, can you start it out and rejoin? We can go with the next presentation.
Yeah, please. Otherwise, there is no point of presenting without videos. I have a lot of videos to show.
Arjun, will you please check
Rajiv.
with Ramesh, Paul Ramesh, whether he's ready. And Paul Ramesh, Varun
Yeah,
Shetty is
hi.
there.
I'm here. I had sent my thing via email as well as I have my screen on, so I could try both ways. I'm not sure which one is to be suggested.
Yeah, try one of them and see whether it works.
Rajiv, can you cancel and we'll try Dr. Paul Ramesh, son?
I'll. Okay. Yeah, I don't know. Is my screen visible? Is my presentation visible? Not visible. Okay.
No, unless this is the share stopped. Yeah, now we can see.
Now we can visible this, Doctor.
Can I start mine or?
Yes, please.
Okay, all right. Thanks for the opportunity. I've been asked to speak about Ecls as a bridge to lung transplant. So let me just start off by talking about our experience with it. Out of the 234 or so organs in 127 patients, that's heart, lungs, and lungs combined, we have done about 11 cases of bridge to lung transplants. Out of the 11, we have done about 7 cases on ECMO. And about 4 cases on the ventilator so far. Our outcomes with bridge to lung transplants on ECMO is around about 57% survival to discharge. Sorry, can you hear me? Can you hear me?
Yes, we can hear you.
Sorry. I thought somebody was interrupting to say they couldn't. Yeah, so this has been our experience so far. So
I'm going to show you pictures about our patients and some of the issues that we've had, along with the indications as well as some of the contraindications to using ECMO as a bridge to lung transplant. So the first thing I would like to start off is, when do you not do it? At least the first three of the absolute contraindications are real absolute contraindications. So if you have ongoing sepsis, now I will talk specifically about COVID and the use of COVID as a bridge to lung transplant at the very end, because it is a contentious. I have to say, all of this whole area of bridge to lung transplant using ECMO is one of active research. It is not very clear. The guidelines are more like opinions rather than based on solid data. But there are trends, and I think once you start doing these patients, you will recognize from the given literature as well as from your own experience who is going to do well with ECMO as a bridge to lung transplant. So if you have any kind of untreated infection, especially in our ICU, there's gram-negative sepsis, or there is multi-organ failure, or any kind of recent malignancy, these are all, these will preclude a lung transplant on its own. And hence, because lung transplants are not going to be done on these patients, there is no point in putting them on ECMO, because it's going to be a bridge to nowhere. As far as the age is concerned, in general, they fix it at around 60, 65. We have not done that. We tend to take the patient as a whole. So if the patient is very fit, the lung is the only organ that is failing, the patient is otherwise stable and conscious, can consent, understands, can do physiotherapy, and the rest of it, we go ahead and consider them as candidates for bridge to lung transplant. So looking at the overall literature that is currently available, the outcomes are not bad. In fact, some of the series have excellent outcomes. Obviously, there's a big bias in how these different series selected their patients. But even at the worst ends of the survival, around 55% on average, 50 to 70%. Our own outcome is around 57% survival, as I said. It is still acceptable because these patients are usually patients who are going to be having 100% mortality without the lung transplant. So now we come to the question of, when do you put a patient on ECMO in order to bridge them to a lung transplant? Ventilatory failure. So this is one of the most commonest things. I don't know if you can see the video. So this is a patient who is usually the kind of candidate who ends up as a young patient with idiopathic pulmonary fibrosis. And this is usually when they actually deteriorate and they are ventilated, they have extremely non-compliant lungs, as most of you are aware of, and you can't really ventilate them. There's absolutely no way that you can do anything to these patients. And so the inability to ventilate a patient, obviously with this attendant gas exchange problem, will be an indication. So here you can see this is one extreme case of our patient who was on the waiting list who deteriorated. She was normally running at around about a 70 or 80 PCO2, which didn't do a harm. But when she deteriorated, the PCO2 went up to about 249 with a respiratory acidosis. This causes a significant RV afterload, even in these patients who are used to these high levels of carbon dioxide, and this on this background of a fast worsening right ventricle. So you would find that a lot of times that the deterioration in the patient is concomitant with the deterioration in the right ventricle, because as the right ventricle is no longer able to compensate for all of the lungs problems, it very quickly kind of escalates the patient to a very critical stage. And it is usually at this stage, and to rather relieve this RV from distending or arresting, that you go on ECMO in most of these patients. As you can see here, the ECMO is excellent at improving gas exchange. So when both severe ventilatory issues, where you're unable to ventilate the patient, and we'll come to one more example later, or severe gas exchange problems in patients who are candidates for lung transplant. Most likely people have already been worked up and are on your lung transplant list, who have worsened, so that the whole team is already aware of this patient's clinical problems. And the other is in COPD patients, and sometimes you can get these severe air leak syndromes. You can see here most of the tidal volume delivered to the patient. Here again, a case of inability to ventilate because of ruptured bullae and torrential air leak. You've got to watch out even when you put these patients on ECMO, and this patient has got attendant pneumonia. They can actually develop potential pneumothorax, and this can develop sometimes even with the chest drain in place. The chest drain was not put for this particular pneumothorax, but was already in place for a previous pneumothorax. It was not able to cope with the amount of lung coming out. And when you are on ECMO, the tension pneumothorax would present as initially as a decreased flow. And this is something that you need to watch out for. These are very critically ill patients. So if you have sudden decrease in flows in a patient on an ECMO, think that it's the possibility of tension pneumothorax. Again, all of these patients have very severe air leaks, and one of the indications in these patients to bridge them with ECMO is if you're unable to ventilate them and you're losing most of your tidal volume down the drains. Now, this is another form of patients with both primary or secondary pulmonary hypertension. The secondary pulmonary hypertension could be against the background of someone whose right ventricle has remodeled itself over many, many years, as usually happens in adult congenital disease that is deteriorating, usually in Eisenmenger's that's getting worse, or in a patient whose right ventricle has not been exposed to this level of hypoxemia and therefore is struggling against this pulmonary hypertension, an unremodeled right ventricle, if you will, as with patients who have pneumonia and ARDS. So in this case, again, if you think about it, the ECMO is for gas exchange, but largely to relieve the right ventricle because a failing right ventricle is a very poor prognostic sign in these patients. So what needs to be done? Depending on to some extent on the etiology and the type of respiratory failure, you could choose the lesser invasive kind of ECMOs. So you could have a bicaval or a veno-venous with a small bore, you could have large bore, or you can have a femoral IJV that's a two cannula system or a one cannula system. We have experience with the one cannula system in about 7 or 8 patients, both bridge to recovery as well as bridge to transplantation. And when there is a significant right ventricular failure, as I pointed out, some of these patients may require VA ECMO. So usually the escalation would be you go on to a VV ECMO. I will illustrate one of the patients we have, but just very quickly, I think this has already been dealt with. So these are the least invasive, and you can ambulate these patients. So this is a patient on the lung transplant list who's had type 2 respiratory failure, but we were able to, because of a body size, the problem with putting the single lumen cannula is that the flows are going to be lower. So if you're going to have a severe problem in terms of hypoxemia, you may not be able to oxygenate enough of the cardiac output. So it may be inadequate. However, if you are able to get your requisite endpoints in terms of gas exchange, either whether it's carbon dioxide clearance or oxygen, then a single lumen cannula should be more than enough. But the great advantage in patients waiting for a transplant is the quality of life. Here you can see a very frail lady. So if she was on the conventional ECMO and you took her to a lung transplant, by the time she had critical illness, myopathy, and sepsis. But with this cannula, you can, in these patients, mobilize them, build their muscle mass. They can do physiotherapy. They can engage with their relatives and so on and so forth. The quality of life for these patients is, while they're awaiting organ, is quite good. This is the conventional VV, which where you put the right internal jugular and the femoral. In some of the patients, the deterioration is so high. I think Dr. Malhotra, Dr. Poonam Malhotra referred to this. These patients are having a fair amount of right ventricular dysfunction already, which is deteriorated, and you may require VA ECMO. Usually you do this in the form of a peripheral VA ECMO. Sometimes if as I said, if you're not able to oxygenate enough blood, you may have to have an additional line. So you have a VV ECMO just before the hyphen. For those of you who are new to the ECMO situation, the words before the hyphen denote where the venous drainage is coming into the pump or into the machine, and the what's after the hyphen is where it's being delivered. So some of these patients can, with peripheral VA ECMO, develop the Harlequin or the North-South syndrome. And in this patient, again, this is a patient, young patient, who's waiting for a lung transplant. You set this right by actually just getting the venous output or to the machine from one of the cannula and delivering some of that back down the venous side, but into the right atrium, in order to make sure that there is some oxygenated blood going to the cerebral and coronary vessels, so that there's no cerebral or coronary ischemia to the upper part of the body. This is important as a part of bridge, because when you have patients who are deteriorating quite fast, so you may put a single cannula and then you may find that's not adequate. You may add another cannula. to improve veno-venous drainage, and that may improve it. Then you may go on to peripheral VA ECMO. Then you may find you have a North-South syndrome. You have to go into VAV. And you try to avoid as much as possible doing a central VA ECMO in these patients because you want a pristine chest when you're going to do the lung transplant. What is the usefulness of this? So as you can see in this particular patient, they can be awake. The most important thing is physiotherapy, their ability to give consent. So when we talk about COVID and lung transplant, it is very important. Some of the guidelines, I'll discuss that with you at the very end, that they are able to consent to a lung transplantation. So again, this is one of the devices that is very helpful in these patients. It's called the Leto device. So you can either have active or passive. And this patient is on VV ECMO, but at the same time is undergoing physiotherapy. This helps build muscle mass. And this has been shown consistently to reduce the time spent on the ventilator, the need for tracheostomy, and the chronic weaning of patients post-lung transplant. So this is a very, very important aspect. Wherein you can do it if the patient is on ECMO. The other way is if the patient has come in suddenly and you want to look at the airways before you decide about the transplant itself. You want to make sure there's no bronchomalacia, no growths in the endobronchial T. This actually is quite useful in patients with ECMO. You would otherwise not be able to do if they were on just conventional ventilator. Sometimes, as in this particular patient, they had a previous CABG and you had to use a peripheral VA ECMO because this patient did not deteriorate. He was first ventilated and then went on and got a lung very quickly. This is a single lung transplant which is done for this particular patient with previous coronary artery bypass graft. The reason we did a single lung transplant, on the left side, the left internal mammary artery was coursing through the left hilum, and hence we could not use that, and we had to do a single lung transplant. Now, I'm going to finish my talk with this. Is it useful in COVID? And this is a big question. So there are two parts to this question. The first part of the question is ECMO useful in COVID? And the second part is, should you be doing lung transplant? So let me come at it from a logical point of view, given what we know already about other things. Just in terms of the fact that this is another, yeah, sure, it's a pandemic, but it's another viral pneumonia. So viral pneumonia producing ARDS. In H1N1, we didn't rush to do lung transplants. We didn't do it in any of the other kinds of viral pneumonias. To just set this apart alone and say, should we be doing it? So the counter to that is given by people who say, oh, but the ventilation in COVID is really difficult. It tears up the lungs are spongy, and so on and so forth. So you could make a case, again, when you have like severe air leak syndromes and you're going on ECMO for other reasons, whether you should be able to, whether you should go on to transplant these patients. If you look at the data that we have in patients who are recovering, who have not yet fibrosed, if you look at SARS-CoV-1, or the one that came in 2003, lung failure in chronic patients who had come out of ARDS but had fibrotic lungs, some of that fibrosis improved even up to 2 years. In over 27 to 33% of patients, an average of 1/3 of patients showed some improvement in the lung function long term. You have to remember the lung transplant has also a finite time, and it is used for patients whose prognosis is measured in months or maybe a year, rather than for patients who can potentially survive 2 or 3 years. So that again makes the question, I'm deliberately raising these points so that you can start thinking about how appropriate a treatment this is. Now on ECMO, the outcomes from whatever data we have from mostly the Chinese studies, which have shown that the mortality has been quite exceptionally high in these patients, and there has been very few recoveries in these patients. So as a consensus, based on a Lancet article, this is the European consensus, if in COVID, you have an isolated lung failure, you have at least 6 weeks post-infection, on CT scan, there is no active pneumonitis, you can see some level of fibrotic changes. The patient is awake, can consent, can comply with physiotherapy because that determines outcome. Remember that you are stealing this organ away from someone who is already on the list with a condition where clearly the prognosis, either it is end-stage Eisenmenger's or IPF with cor pulmonale or end-stage COPD, in whom this lung can go. So if it is going to be given here, the outcomes should match what it would match any other lung transplant, and the same kind of indications, no intercurrent infection and no usual contraindications. So the point here is, don't make exceptions just because it's COVID. You should treat it like any other condition and or any other viral pneumonia. Just to, this thing, if any of you is interested in a patient's perspective, one of our patients who had a ECMO bridge to lung transplant, who wrote a very moving kind of account of his time, both before and during on ECMO and after the transplant. So this gives you a good perspective. And with that, I want to again thank you very much for your kind invitation. I hope you found my talk useful. Thank you.
Thank you, Dr. Paul, for your time. It was a very lovely presentation. Probably at the end of the session, we can wait for some questions. I would let Dr. Varun Shetty take over and take over the presentation and discuss regarding ECLS for heart transplant. Dr. Varun Shetty is one of our consultant cardiothoracic surgeons at Narayana Hospitals. Over to you, Dr. Varun.
Can you hear me?
Yeah, we can hear you, Dr. Varun.
Yeah, okay. I'll just share my screen. Yeah. Can you see my screen now, Arjun?
I
Not yet.
cannot. Rajiv, can you help Dr. Varun?
Yes, sir. It's a MacBook or a Windows, sir?
It's a MacBook.
MacBook, sir. You can do one thing, sir. Just change the settings now.
Yeah.
Okay. Sir, just go to the system preferences.
Okay.
Click on sharing.
1 minute.
Yes, sir.
Hold on. Right.
Okay. Click on sharing, sir.
Yeah.
And check on the checkbox on the screen sharing.
Mm-hmm.
And just click all the options, sir, like media, files.
Wait 1 minute. System preferences and
System preferences, sharing.
yeah, screen sharing. Yeah.
Yes, sir. Select the options, all the options what is all.
Yeah, I've clicked on screen sharing. Yeah.
Sharing. Right, sir. And
Yeah.
just come to just
Yeah. Can you see now?
Yes, we can see, Varun.
Okay. Shall I go ahead?
Yes, please.
yes, sir. Continue, sir.
Oh,
Thank you, sir.
all right. Thank you. Thank you. Good evening, everyone. And I'd like to thank the organizers for this opportunity to speak on ECLS in heart transplant. When it comes to the use of ECMO following heart transplant, the main indication is, and the most important indication is primary graft dysfunction. PGD is one of the most serious complications following heart transplant. The ISHLT classifies graft dysfunction as primary when the cause is unknown, or secondary when there is a cause, when the cause is related to either hyperacute rejection, pulmonary hypertension, or any other complication. Another term that a lot of groups often used interchangeably is the term early graft failure. But the ISHLT is clear on that. It defines early graft failure as the composite endpoint of death or graft failure requiring a retransplant within 30 days of implant. If you look at the incidence between groups for PGD, it varies widely. It's between 2 and 25%. This wide variation is primarily has to do with how different groups define graft dysfunction. Primary graft dysfunction carries a very high mortality. It's nearly between 40 and 50%. And some groups define PGD only as those patients who go on ECMO. Most of the PGD definitions is up to 30 days of transplant, but however, some groups also use the definition of PGD up to 90 days. The incidence of graft dysfunction is higher, especially in the recent years because of the use of marginal donors. Factors such as advanced age, high vasopressor dose, or patients who have been declared who have developed traumatic brain injury following drowning or asphyxia of any kind, and sepsis. Recipients with a higher PVR and a high inotrope score in the recipient before surgery, or those recipients who are on ECMO before a transplant. Now, when it comes to the risk factors, the two factors can be blamed. One is related to that of the donor, and the other is related to that of the recipient. Age. Age plays a risk factor, especially in donors over the age of 50 years. That's because older hearts have a low tolerance to ischemic injury, either because of underlying coronary artery disease or a hypertrophied ventricle and diastolic dysfunction. Ischemic time is another very important risk factor, especially when the probability of PGD increases by 43% for every hour beyond 4 hours. Another important factor is weight mismatch. Also, the PGD is a higher incidence of PGD, especially in female donors to male recipients. Another risk factor which cannot be explained is the cause of brain death. PGD is higher in patients who have had traumatic brain injury following asphyxiation, hanging, drowning, and sepsis. When it comes to the recipient, important risk factors include an elevated pulmonary vascular resistance. Even in those patients who have a borderline PVR between the range of 3 and 4, PGD is often higher. In those recipients who are dependent on inotropes, or who have been ventilated, or who are on temporary mechanical circulatory support prior to the transplant, and in those recipients over the age of 60 years. Now, when it comes to the indication of PGD is often seen with increased frequency, especially in those with congenital heart disease, valvular heart disease, retransplant, and ischemic cardiomyopathy. Now, following the transplant, once the anastomosis are done and there is no problem with bleeding, we often wean off cardiopulmonary bypass with an acceptable dose of inotropes. Now, PGD will be seen as most commonly it will be seen as the right ventricle struggling, sometimes even both ventricles. And in spite of increasing the inotropes, the MAP continues to be below 60, and you have a low index or a high wedge. In that case, we go back on bypass, vent the left heart, and rest the heart for another 60 minutes. At this time, if the pulmonary vascular resistance is to be blamed, then you can start inhaled nitric oxide. And if the left ventricle or any other issues are to be blamed, then you can go up on the inotropes. Even after resting the heart on CPB and making sure that all the other correctable lesions are corrected, the next step is to go on ECMO. Now, there are two options. One is central and the other is peripheral. If you look at what data is available, there is no difference in the outcomes between central and peripheral. Also, there is no difference between the bleeding complications or the need for re-exploration. However, different groups, based on what is their comfort level, some groups prefer peripheral, primarily because, again, you can avoid re-entry into the chest while decannulating. Another advantage is if the patient has PGD affecting the right ventricle, these patients can be put on ECMO, extubated, and then decannulated while on sedation because the right ventricle does not tolerate positive pressure ventilation well. But when it comes to peripheral cannulation, specific complications are that of to do with the limb ischemia, arterial and venous edema. And the other advantage is if a patient is on preoperative peripheral ECMO, you can use the same cannulas in the post-op as well for the ECMO. Now, in those users who advocate central, one of the main reasons for preferring central is that you have better drainage and better flow. You can easily convert the existing CPB cannulas. The chest can be closed over these cannulas, and these cannulas can be tunneled subxiphoid. There are a lot of options when you use central. If for some reason the heart, there are no ejections on the arterial trace and the LV becomes a standstill, you can add an LV vent. You can even convert to an LVAD or an RVAD or even a BiVAD if the duration of support you require is more than 7 days. However, the only downside is you have to reopen the chest while decannulating or while converting to a VAD. But our preference is always to, if we do suspect graft dysfunction and if we rolled out all the correctable lesions and if we have rested the heart adequately, then it is always early ECMO and especially on-table ECMO. We again prefer central for the other reasons, as I said earlier. However, we have used peripheral in instances where the groin vessels have been exposed, especially in a redo where we've already cannulated it for CPB. We rest these hearts for about 72 hours before attempting to load with inotropes. Now, there are different groups who would primarily use ECMO, and there are some groups who would directly go for a temporary ventricular assist device. However, one thing is certain is that ECMO is more commonly used because it is widely available, and many groups are comfortable with the use of ECMO. ECMO can be you can easily convert the CPB cannulas and put the patient on ECMO. The advantage of ECMO is a single ECMO circuit can be used to support both the single. It has its use in supporting single or biventricular failure. ECMO provides an adequate support for up to 7 to 10 days, depending on the oxygenator. Now, if the lung has recovered and the ventricle is only to be blamed, then one can consider transitioning to a VAD. Now, the studies comparing primary ECMO and temporary assist device, they have been shown to have equal survival to discharge. However, maybe a slightly marginal higher success of weaning in temporary VADs. But overall survival is the same between ECMO and temporary VAD as a first resort. However, there are some studies that show that in isolated RV failure, ECMO is better in outcomes when compared to RVAD alone. I think this primarily has to do with the addition of oxygenator. Better oxygenation would help the RV to recover better because these patients are not just dealing with RVAD. They may also have a lung element to it. When it comes to ECMO following transplant, the median duration of support is between 7 to 10 days. The weaning is often the percentage of weaning is often higher, between 77 to 84%, and the survival is at 50%. And the leading causes of death on ECMO are bleeding, stroke, and septic shock. One thing is certain that early initiation on table versus late leads to better outcomes without an increase in complications. Survival is higher in patients. If you compare post-cardiotomy ECMO versus transplant ECMO, survival is much higher because In transplant, the myocardial stunning is often reversible, provided you have the donor you using an acceptable donor. But compared to absence of PGD correlated with better long-term survival. In patients with transplant, comparing those with and without PGD, obviously those patients without PGD have better survival. But in those patients who have had PGD, have been put on ECMO and survived, they have comparable outcomes to those without PGD as well. So the take-home message is ECMO can be used as a reasonable salvage alternative for patients who develop PGD following transplant. Between 2010 to 2019, we've done a total of 47 transplants. The indications for transplants, the most common indication is for DCM, followed by ischemic, restrictive, congenital, and we've done a few ARVD and myocarditis. Our use of ECMO is about 19%, and out of which we've had about a 4% mortality on ECMO. So in conclusion, any transplant program must be prepared for the use of ECMO, because you cannot start a transplant program without having an ECMO backup or the expertise of ECMO. This is because in the transplant thing, you're dealing with much sicker recipients who might be on a ventilator, who might be on inotros, who might be in advanced cardiogenic shock. And also on the other hand, you have a very shrinking donor pool. And this is more common in the West, where you have to use marginal donors. When the heart does not respond to inotros, pulmonary vasodilators, cardioversion, or temporary mechanical circulatory assist should be decided. Now, the choice of ECMO or VAD is up to the center's experience. The survival of patients without PGD is higher in comparison to those with PGD. However, in those patients who have survived ECMO, their survival is comparable to those without PGD. Survival in those patients who have been salvaged with temporary circulatory support, their survival tends to be higher. Options include, for mechanical circulatory support, there are various options. Most commonly ECMO. Sometimes, if it's only an isolated ventricle problem, single ventricle problem, then an LVAD and an RVAD can be considered. And if you're very sure that the lung is not to be blamed, then a BiVAD should be. Lung is good, then the BiVAD can be used. ECMO will be most commonly used because of the ease of implantation and its wider availability. Thank you.
Thank you, Dr. Varun Shetty, for a lovely presentation. Thank you for your time. I would call the next speaker, Dr. Riyan Shetty, who is the Director of the ECMO Services at NH and also a Senior Consultant at the Pediatric Cardiac Intensive Care Unit. And he will be speaking about extracorporeal cardiopulmonary resuscitation. Dr. Riyan Shetty, over to you.
Hello.
Yeah, we can hear you, Dr. Riyan.
Okay.
So you can take the access, sir.
Yeah. Can you go full screen? Or... Yeah. Can you see me, Rajiv?
Yes, sir. No, sir.
Okay, I'm not going to switch on my camera, okay?
Yes, sir. No problem, sir. Continue, sir.
I'll just check whether it works. Is it changing there, Rajiv?
We can see a screen, Dr. Riyan.
It's the first screen, is it?
Yes, sir.
Yeah, the extracorporeal CPR with your name on it.
Okay, now, does it go to the next one now?
No, sir. Let me check once again.
No.
Okay, Rajiv.
Yeah, now it's moving.
Is that you, Rajiv, or?
No, it's Dr. Arjun speaking. Riyan.
No. I'll speak to Rajiv, but 1 minute.
Yeah, sure.
So you just click on the screen. It will be.
Yeah, it's coming, no? It's coming through, right?
Perfectly, sir.
Okay. Thank you. Thank you. I'll start, Rajiv. Thank you so much after all that hard work.
My duty, sir.
Okay. Good evening, everybody. I think it's the last talk. Thank you for the organizers. Thank you, Dr. Muralidhar. It's my great pleasure to be interacting with young anesthetists and intensive care specialists in the Bangalore chapter. Not always do we get an opportunity to talk to them. So I'm going to talk about mainly on extracorporeal pulmonary cardiopulmonary resuscitation, or what's called as ECPR. I'm not going to elaborate on what kind of ECMO we use for it, and I'm more going to talk about what's the concept and how do you implement it? Where are we in the ECPR program in Narayana? So ECPR mainly is extracorporeal membrane oxygenation cardiopulmonary resuscitation. 99% of the times it is veno-arterial ECMO. The choice is very much how fast you can open the skin. That's called a slash. So how fast can you open a chest or a groin and put two big cannulas in so that you get a venous access and an arterial access. So it becomes a veno-arterial ECMO. Now, I've been listening to all the lectures, and a lot of times the choices have been already mentioned. So I'm going to go in a slightly different angle. I want the audience to understand where we are with ECPR in the world and in India. If you go to the latest 2019 AHA guidelines, as you can see in the screen, it clearly says there's a class 2B level of evidence of C. Weak evidence, but benefit more than risk. They say it's maybe considered, maybe reasonable to deliver ECPR, but they clearly mentioned it's a rescue therapy when conventional CPR efforts are failing, and not to forget in the settings where it can be implemented quickly and supported by skilled providers. So it clearly says that you should have lots of experience and skilled providers. So the natural curve is to do more elective ECMOs, do respiratory ECMOs, and a lot of complicated ECMOs, and then only daunt on an ECPR program. Why have they said the level of evidence is low? Because most of the trials which they have been publishing is mostly a single center trial. There is varying inclusion criteria and decision to perform ECPR made on case-to-case basis. Varied clinical and patient factors did not define selected patients. There's no randomized controlled trials, no data on cost effectiveness, resource allocation, which is so important in India. You have a patient who is arrested, and if cost is a factor, there's really no time to talk to the relatives, and also the ethics behind it. So if you really go through the ECLS registry, if you see the neonatal and pediatric ECPR results, they're pretty more than 140%. But if you really look at the adult ECPR results, they vary below around 29%. Some cases, example, if you have a young individual, young adult having without comorbidities, sudden arrest, secondary or presumed cardiac arrhythmia in a hospital which has cardiac ECMO as a team, then he's a better candidate than an elderly patient with metastatic malignancy and has a cardiac arrest. Also, out of hospital cardiac arrests have a worse outcome, which I'm going to talk to you very soon. So if you really look into the number of studies done with the ECPR, the biggest study is the ELSO registry. But other than that, very early on, even in 1994, Chen et al., that's the Taiwanese group, had a paper on in-hospital cardiac arrest, and Shin also, I think, also from Taiwan, also had a beautiful paper. As you can see, in-hospital cardiac arrest survival to discharge was between 29 and 35%. So there was lots of there's a lot of excitement revolving around these two studies, especially because what they found out is if there's a duration between the arrest and the CPR was shorter, then the survival was better. So what they did was, what the world did was, then they extended these services to an out-of-hospital scenario where you have an out-of-hospital cardiac arrest, resuscitated, either pre-hospital ECMO or hospital ECMO, and various studies came out. And then you can see, if you can see lower down, you can see Boguin et al. They did a huge series on out-of-hospital cardiac arrest. I'll talk to you about it. So out-of-hospital cardiac arrest looks something like this. That's an empty metro station, and then suddenly it becomes like this. This is one of the French stations, and this group actually presented this out-of-hospital cardiac arrest registry study where they looked into 24,000 out-of-hospital cardiac arrest. 12,666 went without ECMO, and the survival was actually 8.6%. Whereas they initiated ECMO either pre-hospital, that's 136 pre-hospital, or a 389 in hospital, and their survival respectively was 15% and 7%. Overall survival when a patient had ECMO was a dismal 8.4 for an out-of-hospital cardiac arrest. What they saw was if the initial shockable rhythm, initial rhythm was a shockable rhythm, or if there was a return of spontaneous circulation, or it was a pre-hospital ECMO than and post or in-hospital ECMO. That means arrest happened outside, he was ECMO'd outside and then came in. They had a better survival than others. So it actually, because of the study, it made the world even more confused about whether ECPR for out-of-hospital or in-hospital cardiac arrest is really worthwhile, because as you can see, the survival rate is very dismal, around 20 to 30%, depending on where the arrest has happened. So that's what I said. And then now coming to the neurological outcomes, essentially varied widely from 50 to 85% of survivors, according to regional variation, according to the age of the patient. So there is absolutely no study saying that a certain set have better neurological outcome. What was interesting is that even in the Paris study is that there was failure to cannulate almost 11% of their patients. That's 58 patients. So what it essentially looks like, it's like a bridge like this. We don't know which one to select, which patients to select, and we don't know whether the outcomes are good on the other side of the bridge. It's very foggy. Essentially, what we are trying to bridge to recovery. We are trying to bridge to decision. Sometimes lately it could be even bridged to saying goodbye, even bridged to organ transplant. So I'll straight away go to the structure of ECPR. There should be, if you're setting up an ECPR program, there should be a designated ECPR code, clear indications and contraindications, protocol for initiation, team leader with the authorization to request for ECPR, and the necessary equipment and personal readily available. So once you got all that, the algorithm will look like this. ECPR criteria met, yes. Then is there any contraindication, and then only becomes a candidate for ECPR. How do you implement an ECPR program? What you need to really look at. I'm just waiting for this one. Sorry, the slides are a little slow. Oh, I think I can't see a slide. Just give me a second. I think I can't see a slide. I'm just looking at the phone. Yeah, there's a nice paper by Peter Lawson from Toronto. They have made it into 4 intervals, as you can see. Interval 1 is between the arrest and CPR, conventional CPR, and -1 is between witness and the arrest. That's a pre-event. You have to keep these things down, and then have once the arrest has happened, quick CPR should be started, compressions, airway should be secured, and then there should be a clear leadership to call the Ecpr team if there is a team available. And in stage 3, once they arrive, they take over. There is a cannulation procedure. Blood bank should be informed. Equipment should be ready, and the team works together to get on the ECMO machine and get a pump flow and then get a full flow. When you're trying to return the circulation, that's the stage 4. So by looking at this, you can clearly understand these 4 intervals. And what's most important is the interval 1 and interval 2. And of course, once you go on ECMO, you should have clear guidelines how you target the post-cardiac arrest care. So limiting the time of no flow, excellent conventional CPR, location should be a well-controlled environment, protocols and equipment should be ready to launch eCPR and cannulation. These key components. Performing high-quality CPR is essential no matter the indication of eCPR. Actions are decision to call as early as possible, ideally within the first 2 rounds of resuscitation medications are given. There should be clearly whom to call or have a eCPR code blue team, and role assignment and leadership is extremely important. A lot of studies have shown that there is reduced survival once you have a very low arterial pH post ECMO, higher lactate, even lactate clearance has been talked about a lot, and any end organ injury, especially the brain. Longer duration of eCPR is associated with adverse neurological outcome. Post eCPR management, you should target flows and perfusion. Any cerebral and myocardial reperfusion may be associated with altered cerebral autoregulation, myocardial stunning. So they need an adequate cerebral perfusion. And if there is no myocardial activity for more than 48 hours, then you are a little bit worried, and decompression of left ventricle or left atrium should be aggressively sought out, especially in VX. The risk of intracranial hemorrhage in eCPR is higher than in patients supported with ECMO, so careful use of anticoagulation necessary. Neuroimaging should be used for assessing this. So I'm coming to the end of the talk. Is this really possible in India? I don't think there's active eCPR program very active on out of hospital cardiac arrest, but in hospital cardiac arrest for certain groups of patients, like in our hospital, if you look at the pediatric cardiac, we have an active program. We've done about, this is a little old data, but end of 2019, we have done about 74 in the last 3 years. And then if you can look, the survival to discharge is almost 37.8%. So what's good to see is the average run of ECMO is shorter, unlike in adults. So it's much more shorter. And what's nice to see is the average downtime is running between 23 and 33 minutes. It's not important how the short the downtime is. It's always important. As I said, adequate cardiac compressions are the most important thing. So to conclude, in hospital, cardiac arrests have better outcomes. Performing high quality CPR is very essential. Strong structure and team is required. We need to sort out consent and the cost burden to patients. Ethically, it should not be a bridge to nowhere. It should be a bridge to something. Thank you.
Thank you, Dr. Rian. That was a lovely presentation. I would like to thank all the presenters for keeping their time and having a very good discussion. The floor is open for discussions. If anyone has any questions, please raise your hand and we can discuss on the same.
The panelists can unmute and comment and then start the discussion, please. The panelist, Dr. Kumaran is there? Dr. Kumaran, Jayaprakash, Hemant, Krishna Prasad.
If no one's initiating, I can initiate something.
Yeah, absolutely, absolutely. Please feel free. Julius is around. Dr. Julius, please.
So, Rian, what is the longest time that you will allow before you're informed about an in-hospital cardiac arrest to decide to turn down ACPR?
Julius, did you ask what's the longest time?
Yes, where you would, where you would just still go and put an ECMO. Like somebody's been massaging for 1 hour, 2 hours.
God. Good question, Julius. Again, depends on children and adults, the outcome and everything. But I would there's no place they will tell you what's the longest time. But if you think you need 30 minutes to initiate, I think it'd be fair to say 30 minutes, because if you are called at 30 minutes and then take another 10 minutes to reach there, and then you take another 20 minutes to candidate and get on full flows, I would say 30 minutes is what I would say, Julius. But the other day, you know what happened. You came for a resuscitation after about, I think that's why you're asking a question.
No, that is not why I'm asking the question.
Yeah. So just for the people is that we were thinking of putting a baby on ECMO after an arrest, and we resuscitated, and we decided not to, and then we resuscitated for 2.5 hours. It was a post VSD with low EF, and then he went home last week without any significant neurological deficits. These questions are extremely difficult to answer. How long it take, how long we should wait.
I don't know if Poonam also remembers from the Delhi conference which she had conducted where Dr. Bartlett was there.
Yes.
So he was saying, if somebody calls you after half an hour, you just tell them we are not putting.
No, in fact, Dr. Julius, in fact, I very much agree with you. I was just going to say more than 20-25 minutes of arrest without any resuscitation done, particularly when you see the patient in the emergency, then those are patients where it should be a big no-no. I remember Dr. Bartlett saying that very clearly in the conference. I have seen it myself in our emergency. We are called just for an ECMO in the emergency very many times. But the moment you see a young child who's awake, who's having chest pain, whom you think could be a cardiogenic shock or a myocarditis, you would think of an ECMO right away. At least the patient's awake. But the moment you see a patient who's not moving, you know that it is maybe a DNR kind of a thing where you're lucky, Rian, whatever you're mentioning, your patient went home after the resuscitation for 2.5 hours. But what I have seen of most patients beyond 40 minutes, 45 minutes, if you've not attacked the patient first and foremost there with CPR, and then immediately put the patient on for a ECMO within half an hour or 45 minutes have elapsed, the results are disastrous. It's wastage of manpower and money.
What he was saying is eventually you might decide to put somebody on ECMO later than 30 minutes, but at least the next time around, they will remember to call you before it is too late.
Right, very right. In fact, today we had a patient who had a stenting done in one of the Delhi hospitals, private hospitals, had a stenting and then went into low cardiac output and was put on an ECMO. He revived on 5th day, ECMO was weaned out. He went home. 48 hours at home, he succumbed again. He was put in another private hospital from where he was rushed to us today. And this is at 3:30 when I saw him. We were ready to say a big no. The ECMO was on and they wanted us to put a VAD. Now, already there's an IABP and an ECMO, and this is a patient who's been struggling last 7-8 days, ECMO in and ECMO out. And now with two of them going, where do you put in a VAD in a patient who's not even neurologically, feasible to do anything? And then the moment we did the CT, we saw massive intracranial hemorrhage and pointing signs. So those are patients where you feel so unfortunate for them. But I think for commercial gimmicks, we should never allow ECMO to be used as a subsidiary in a false hope to the patient's relatives.
Yeah, this is something which I have always reiterated, that before you put the ECMO, you should know what the next step is.
Right.
You should be clear if the patient is for recovery or for transplant. And what if your expected recovery doesn't happen? Do we have a plan B? Are they going to have a possibility of putting a VAD? Or at least we are clear, this is where we will go and this is where we will stop. So that plan should be somewhat clear before you even institute an ECMO is what I think.
Totally right. Totally agree. But Ecpr with cardio health, Riyan, has come up in a very nice and a big way. In most of these centers where, let's say during COVID, we saw medical specialty Calcutta people picking up patients. We saw Dr. Pranay Oja pick up patients in Mumbai. We saw a lot of Saudi Arabia patients pick up patients, also in Qatar. I kept hearing of them having COVID patients picked up by the helicopter or by a plane and brought an Ecpr done with the cardio health. It's miraculous how soon you can reach and how soon you can put it in and how the patient does recover. But most of them have given a mortality rate of as high as 54, 55% also. Those are the data coming in for COVID Ecpr transport on Ecpr. So I don't know where we are. I think it's still something which is new and we all will take some steep learning curve, or maybe, I hope not a plateau learning curve to do it. Let's see.
I think Paul has got a fair amount of experience with adult Ecprs.
Yes, he would.
Yeah. Thanks, Julius. We only resuscitate patients who are on the list or who are witnessed in hospital. The longest external cardiac massage for which we had a successful Ecpr was about 70 minutes. Because by the time we could, this is quite some time ago, about 6-7 years ago. But if it's a witness arrest, and as I think as Riyan was saying, if the cardiac compression is good, then I think you can go for it. We do not do out of hospital arrests at all. So.
I have been able to take a child through after 1 hour of effective massage. I mean, the child already had a line, and we were able to tell it is effective compressions. So we put on.
The only other thing I wanted to say about the Ecprs is if you do not get spontaneous rhythm back or a spontaneous circulation back with your initial peripheral resuscitation, it is always better to go in for intracardiac massage and also to vent the LV, because most of the time the post thing is because of LV distension. The other point I wanted to make was about poisoning. Because in poisonings, these patients do well even after about 1.5 hours of low cardiac, extremely low cardiac output, very high inotropes, and then suddenly crashing. You keep massaging them, you can go on to the ECMO, and we've had at least 2 or 3 patients with calcium channel and beta blocker poisonings who after 4 or 5 days recovered completely. One of them was a medical student, he's a doctor now, by the way. So, but it's remarkable in poisonings. So etiology also matters.
I agree. We've seen a lot of, in northern India, we have a lot of alum poisoning.
Yes.
They use it as a rat poison, and we've seen it in our pediatric babies, and they respond very well to ECMO. It's like a lavage, and they come out very fast. 4th, 5th day, you're ready to wean them off. Some of them whom we put in adults, a couple of them, they went into AKI because alum causes a lot of kidney injury. So we had to use CRRT with ECMO. But I remember all those 4 cases and we salvaged the patients on ECMO. So in fact, ECMO for toxicology is very, very, very in. Even in a snake bite patient, we put ECMO once. A patient had a bad viper snake bite and had a very distended LV. And the moment we put in the ECMO, the patient did well. And about after 8 or 9 days, we could remove the ECMO. So I think it's how you predict, it's the experience of the team, it's the experience of the intensivists on duty and the people on duty at that hour, and the luck of the patient also.
Yeah, if it's a Sunday or not and other things.
Totally agree. Totally agree.
Dr. Julius, I want to share my experience on Ecpr. There was a 95 minutes CPR patient alive, and I was working early in Qatar. This is outside hospital arrest, witness arrest. Compared to India and other, what was the problem here? See, India, we cannot reach within 10 minutes ambulance anywhere.
Yeah.
Any other country, 10 minutes we can reach. And their arms are full setup. No one use manual like the CPR like they do as a Lucas. Each ambulance they have Lucas. Then they're like reach within 5-10. We saved many patient like 95 minutes CPR. After 1 year, she gave a birth to baby. Just imagine what kind of recovery she has. They put on a FEM VA ECMO, then she is recovered afterwards. After 25 days of ECMO, she is weaned off.
What was the cause of arrest?
I think maybe non-cardiac. It's not like we did this one. She was fighting with she's Saudi 28 years female. And due to some children's problem, she was shouting on someone. She's arrested, witness arrest. Started doing CPR in the park, one of the big well-known park. Then immediately called ambulance. Within 10 minutes, the ambulance reached. The patient put on Lucas. Then after 95 minutes, patient we put on ECMO. Then after putting on ECMO, rhythm back.
Yeah, I guess the key is that effective cardiac massage. If it is there, then you have a good chance of getting things back to normal.
Yes, even on baby also 90 minutes CPR. We witnessed arrest in ICU. That is actually inside hospital. And unfortunately, we are not able to do femoral cannulation. Then we opened the chest. We put on ECMO. But unfortunately, that aorta also is fully infected. Then again, we went back to fem echo, fem jugular actually, fem jugular. We converted to fem jugular.
Right. So this is the other question. Would you prefer to use peripheral cannulation or central cannulation? As Varun's also been saying, it depends a lot on what the center is experienced with and what people are comfortable with. In an arrested situation, percutaneous cannulations are probably not the right thing to do. Open cannulation, whichever place you're doing, is probably better because it's hard to determine which is vein, which is artery, and all of that when you're in a state of cardiac arrest.
The problem is everywhere surgeon cannot be available, no doctor, because most of the centers in Qatar, most of the ECPR will go to non-cardiac centers. Then they have to be trained all like intensivist or anesthetist, whoever it may be, they have to train. For open technique is not possible. At least they will do with Doppler. Sometimes we want to go for VA ECMO, that will convert to VV ECMO. Sometimes you want to go for VV ECMO, it will go to VA ECMO because it's very difficult to find out artery and yeah.
Actually, in a scenario inside the hospital, it's easy to decide, especially when we are in the cardiac OT scenario. The moment you go from the cardiac OT to the pulmonary ICU, you will just think of a percutaneous limb EV ECMO. You won't even think of a VA ECMO there. And to my mind, because we people are not so experienced, when I have to go there, I find it perplexing for the first 30 minutes or so. Then you settle down. But you're not used to those cannulas, those sites. You're so used to a central ECMO, and it's so easy to do it because there's always a surgeon there, as Dr. Natarajan said. But at the end of the day, I personally feel it's the experience, as Dr. Julius just rightly said, of the center, how they are equipped, who's there at the time, is there a surgeon available or not. But I think every intensivist today is gearing up to put percutaneous cannula.
Yes. Yeah, that's a good thing.
Yeah. Arjun, are there any questions on the chat box?
No, I can't see any, sir.
And is Dr. Vaikar available? Vaikar yesterday was saying that he could not pose any questions. Dr. Vaikar, are you available? If there are no questions on the chat box, is there any other point of discussion? Anybody wants to ask any question?
There is one question which says, is it mandatory? Is it mandatory to have a hemoglobin of 10 grams per deciliter in patients with viral pneumonia on VV ECMO?
Which
Jumana,
is directed.
Dr. Jumana, do you take the question?
Jumana, are you available? Jumana, can you answer this question? Anybody in the panel can answer?
Yeah, I mean, this has always been a bone of contention about what the exact, the intensivists sometimes prefer to undercorrect at 8 grams. And previously, when we first started, it was at 12 grams. But if you look at the existing literature for anybody in terms of optimal flow and optimal oxygen transfer, I think most of the units agree for about 10 grams, not just viral pneumonia, but any other cause as well. 10 grams is the minimum, most optimal value that you end up with. So I think 10 is quite a reasonable number. But there are units that run it at 7 or 8. Yeah.
If you look at the ELSO guidelines for VV ECMO, they still recommend 14.
Correct. That is right. But
yeah, most of the people do not go that high for various reasons. But 10 should be something which is reasonable. As Paul said, there are a lot of people who think that 8 is okay. But for venous ECMO, it is probably more important to keep a higher hemoglobin so that you have adequate oxygen delivery. And we don't, I mean, rather than looking at saturations, you have to calculate the amount of oxygen that is added to the blood and how much oxygen is being delivered to the tissue.
That's right. The oxygen content becomes more important in those situations. Oxygen content of the blood, arterial blood, and I would think that the requirements in a VV ECMO as compared to V ECMO slightly different. VV ECMO you need to maintain a higher hemoglobin as compared to VA ECMO. Do you agree with that, Julius?
Yes. I mean, as I was saying before, the recommendations of ELSO is to maintain a hemoglobin of 14.
Yes,
for VV.
Right. I agree.
But a lot of patients who are in sepsis, I mean, with pneumonias, there is an element of sepsis. They're on high-end antibiotics. You're giving an ECMO on such a patient. Liberal, we've been talking about restrictive blood transfusions in recent times. Even ELSO guidelines say the same for blood transfusion during ECMO. But having a hematocrit of 32, 34 and above for an Indian population, particularly if she's a small-built woman, with a hemoglobin of 8, 9, somehow surprisingly we see them surviving. We may not be the cutoff of even 10, 14 is a distant dream, but you see them surviving, and sometimes you wonder what is there in their metabolism with a hematocrit of 34, 35, not even touching 40, and a hemoglobin of 8, 9 after giving 2-3 units of blood. they survive. In the field of so much of inflammation and sepsis with viral pneumonia. And
Right.
so though we need to maintain it higher, but most of them, I think it is the survival instincts in some people with low hemoglobin. They do survive.
ಅವರು ಫೋನ್ ಮಾಡಿದ್ರು, ಹಿಂಗೆ ಲೇಟ್ ಆಗಿ ಹೋಗಿದೆ ನಿರಂಜನ್, ಮತ್ತೆ ಇನ್ನು ನೀವು ಅವ್ನು ಕೇಳಿದ್ರು ಫಸ್ಟ್ ಅವ್ನಿಗೆ ಹೇಳ್ದ ಇಲ್ಲ ಸರ್ ವರ್ಕ್ ಆಗಲ್ಲ ಅಂತ ಹೇಳ್ದ ಅವನು. ಮತ್ತೆ ಸರಿ ಬಿಡ್ರಿ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಅದಕ್ಕೆ ಫೋನ್ ಮಾಡಿ ಸಾರಿ, ಡೋಂಟ್ ಫೀಲ್ ಬ್ಯಾಡ್, ನೆಕ್ಸ್ಟ್
Please keep your mic off.
Niranjan,
ಏನ್ ಮಾಡ್ಲಿಕ್ಕೆ
your mic is on.
ಏನ್ ಮಾಡೋದು?
Niranjan, I think your mic is on. And I think we are overshot the time by 20 minutes. I think it's time to say goodbye. Thank you for joining us. I am really grateful to Arjun, Kumaran, Jayaprakash, Hemant, and Krishna Prasad for joining and leading the discussions. And the speakers, Jumana, Poonam, Varun, Riyan, and Ramesh have done very well, and I am grateful to them as well. And I would like to thank the Indian College of Anesthesiologists, Bangalore chapter of ISCCM and FCA for their support. And Niranjan's video-based transport of ECMO will be done in the next event, probably in April. We'll be announcing it. It could not be done this time. I'm sorry about it. And thank you very much. And we will meet again sometime, somewhere. Thank you so much.
Thank you, Dr. Muralidhar. Bye.
Thank you.
Thank you.
To everyone. Thank you.